Evening, sir.
Sir, good evening.
Good evening,
Hi.
Dr. Rajiv. Good evening, Dr. Rajiv.
Good evening. Hi.
Good
Hi,
evening.
good evening. sir.
Hi Rajiv.
कैसे हो यार?
Good evening, sir.
सर अभी ठंड पड़ रही है दिल्ली में?
हाँ?
सर आपकी आवाज नहीं आ रही ठीक से।
हाँ, सर,
सर,
थोड़ा
दिल्ली में
connection-
ठंड पड़ रही है सर?
ठंड? नहीं यार ठीक है, अब तो डे टाइम में 26-27 हो गया है. इवनिंग में नाइट इज प्रीटी ओके. आई थिंक वी हैव वेरी प्लेजेंट वेदर राइट नाउ.
यूक्रेन का इफेक्ट नहीं पड़ रहा सर दिल्ली?
मेरे ख्याल से यूक्रेन इस हफ्ते खत्म हो जाएगा यार. आई थिंक इट्स मैटर ऑफ डेज.
उसने बोला भी है ना पुतिन ने कि wants to go to Armenia to have a cup of coffee and a bike through Ukraine.
Hello Mahesh.
Hi, Rajiv.
Hi Ramesh.
Good evening, sir.
So I think it is a wonderful start for the fellows today, and well done Anjul, everyone involved in the team. I think you've done a wonderful job, and thanks for accepting to be the first teacher. And
ईशान वो ओपनिंग बैट्समैन है सर वो.
it is Gavaskar or Kirbani that needs to be seen, or Farooq Engineer. I'll start on time, Anjul, or you're going to give introduction and then we're going to start with Prashant?
Sir, I thought I'll just I'll take just 30 seconds to start and then I'll hand over to you and then to Mahesh sir. आप लोग थोड़ा सा introduction of this class and then we will start the proceeding.
So it is 8:30. We should start.
Sure.
Yeah, exactly.
Hi, good evening everybody and welcome to this class on PICU fellow core exam classes, and I think it's a wonderful initiative taken by Dr. Rajiv Uttam sir and Dr. Mahesh Mohite sir for the fellows for their exams. I'll just invite a chancellor of the College of Pediatric Critical Care, Dr. Rajiv Uttam sir, to say a few words about this class and the initiative that they have taken. Rajiv sir.
Thank you very much, Anjul. And I think most of the hard work has been done by youngsters, Anjul and Minhaz. We have Dr. Mahesh, Dr. Namit, Shrishu, Madhumita, Dr. Otiv. Everyone is involved in the care, and Manish. And, what we thought was, what we found, the fellows were finding it difficult because, we have not a uniformity in the teaching process. Some centers excellent, some centers have come up. They're not as geared for the teaching as the few lectures, which is commonly asked in the examination. They're asked, so if the fellows attend these classes, I think about 70 to 80%.
Can you
of
hear me?
Yes sir.
Sorry?
Hi, good
Yes,
evening.
sir. Good evening, sir. Welcome.
Can you hear me?
Yes sir, we can
Yes,
hear
sir.
you.
Yes, sir, we can.
Yes.
Yes.
Yeah.
So okay. So what we decided that if the classes are joined by these fellows,
I can't hear you.
80. Hi, Shekhar.
Yeah, I can hear you. Yeah.
So 70 to 80% of the course would be covered in these lectures. We have made it on the basis that, the long case discussions, how it is end of the lecture, there would be some MCQs, the sort of pattern which you're going to ask in examination. So I think it's going to be a wonderful help for the fellows, and I'm sure all the fellows will be joining and getting, a lot of benefit from this. So thank you very much for everyone for joining in, and I'll ask our chapter chairman, Dr. Mahesh, to say a few words, and then we will start with the class.
Good evening all, and thanks all the whole team to organizing it
at such a short notice. In fact, today is the first session of this, and we started this program last month, and it was in a stepwise fashion, and henceforth is going to be every Wednesday and Thursday, 8:30 to 10:30, all PICU related programs. So this one was the last one to join actually. We had the previous other 2 Wednesdays being already on nursing course, and now first and third Wednesday is going to be PG teaching program. As Dr. Rajiv said, this time there are a lot of uproar regarding the difficulty level in the exams and all, and we realize we don't have any structured curriculum on which the students can read on. And 1 year candidate, everybody said Rogers can't be completed and we don't have time and all those things. So what we decided, we'll just at least record 20 important peak segment talks of 1 hour, 1.5 hours, and these will be archived. The links will be archived on the website. So even those who can attend now live can ask questions and interact. Those who can't, they can revisit this. And even if they know this, plus the relevant literature in this, I think that will be this. We said kind of with consensus opinion that 60 to 70% MCQs will be based on these 20 odd talks which are going to be there. And it's not like a short, learning process continue till the end. And here Dr. Shekhar sir is there, and he will tell us what is learning, because I always feel he's the most keen student all along whenever I listen to his talks, these things. So that goes on and on. But at least by the time you clear your fellowship program, you should be having at least the basic knowledge of all intensive care. And that's the aim of all this trend. So we won't be talking about much of evidence and all. We'll be giving only the hardcore physiology, physiological understanding, applied physiology, and the relevant talks. Thank you very much. First of all, thanks the whole group. Anjul, Minhas is our man Friday. Put him into any group and the thing succeeds. And that's a clue to the future presidents also. He's the one person you can't afford to be away from any of the programs. And my friend Namit is there. And of course, Dr. Rajiv and all the seniors, Manish and Madhu Otiu madam and everybody. Thank you very much for taking up so far. And it's over to Dr. Anjul for the further proceedings.
Thank you, sir. Thank you for the encouraging word. I just wanted to just introduce the team. We have 4 national conveners for this program. As Mahesh sir said, we are going to do it on first and third Wednesday of every month. Myself, Dr. Manish, Dr. Minhas Sheikh, and Dr. Lalita, we are the 4 conveners, and I thank all of them for joining together and starting this program. I think we are going to start with a bang. And I'll hand it over to Dr. Manish.
I have a question. I have a couple of questions.
So we didn't start the topic.
No. It's about the process and structure. The first question I have is how much there are so many events happening right now, educational events. How much of an overlap is there between you're going to do it twice a month, correct?
Correct, sir.
2 times a month.
Yes, sir.
How much overlap is there for this time slot as well as for this day slot with other things that people want to do?
No, sir. I'll answer that, sir.
Yeah.
We have taken Wednesday and Thursday as a standalone for PICU related topic between 8:30 to 10:30. And all Wednesdays and Thursdays evening 8:30 to 10:30 Indian Standard Time will be allocated to only PICU, and there is no overlap. There is only going to be one PICU topic or PICU session at a given time. So now, as I said, yeah. So
that includes the nursing also, or not?
Nursing is second and fourth Wednesday. PICU fellowship teaching is first and third Wednesday, and Thursdays. First and third Thursday is going to be a question kind. We call it as mentor and mentees. So a case being presented by a fellow and taken up by a mentor, and one expert joins. And the second Thursday is going to be a legion. The international speaker gives a deliberation. And fourth Thursday is going to be a PICU friend. So the other specialty person who helps us in PICU.
I saw that before. Yeah.
So that's kind of a thing.
So the second suggestion, it's not a question, it's a suggestion. I think it would be useful because you have several levels of training. It would be useful to get feedback from people who have completed, whether they have taken the exam or not, just to find out what they have been exposed to.
Okay.
Because if they've been exposed to only 2 or 3 cases of ARDS, or 10 cases of ARDS, it would be unfair to ask them very detailed questions about how to recruit the lung and this and that. That somebody who has done 3 years of fellowship should know.
But
So it
Shekhar,
would be useful to find out each level's training, what their experience is, so that you can then decide how to formulate the question.
Shekhar,
Because go ahead, please.
sorry, just to answer your question, these lectures are meant for what is there for the 1-year fellowship program, mostly.
Okay.
Yes.
We have 2-year fellowship as well. We don't have 3 years in our college. There's a DM for that. But you got to ask these basic questions, which is everyone who is doing 1-year fellowship is supposed to know. And what we found why it was important, because even these basic things were varying between different centers. So they didn't have a basic knowledge of the things which were supposed to know for 1-year candidate. So whatever is being done here is going to be, which is relevant for 1-year IDPCCM fellow.
I don't remember right now, but when we formulated sort of what should be a 1-year, 2-year, 3-year program, I think there were goals and objectives for each one of those levels of training. It is there.
Still there.
So I think getting feedback from them and using that can be the template to. So you're saying that this should be geared towards 1-year trainees.
Shekhar, we have, suppose we have 100 fellows, about 90 are 1 year, and then we have only 10% who are taking 2 years. Because
Okay.
there is a problem about DNB now. I mean, most of the centers have to take a 2-year fellow. So the bulk of our fellowship is 1 year at the moment.
Okay. Thanks. Sorry.
Yeah.
Go ahead, Anjul.
Thanks for your comments. Yeah.
Thank you, sir. Thank you, sir. And your comments are always very helpful, and we have noted it down. We'll go ahead and find out the data. Now I hand it over to Dr. Manish to introduce our experts and the speaker for today.
Yes, thank you, Dr. Anjul. So today, to start off, we have 2 experts. We have planned Dr. Madhu Ote ma'am, the past chairperson of IAP Intensive Care Chapter and director of KEM Hospital. Dr. Shishu, he is a senior director, pediatric intensivist of SIMS and Surya Hospital. And as our speaker, we have Dr. Prashant. He is a senior consultant of Hope Hospital, Jaipur. So I'll just, I think we have already a little bit late. So I'll just, to start with, we have a few questions. So I'll just request Dr. Shishu to share the slides, share his screen so that we start off and then we'll go ahead.
Yeah. Good evening. I'll be giving just 1 to 2 minutes to read the questions, frame your answers, and after the lectures, you can go ahead and type the answers in the chat box.
You can take pictures of these questions, if you like. Make it full screen, yeah.
Yeah, got it.
Srishu, open the question fully.
Yeah.
Read the question.
You'll have to identify and choose one of these answers for A and for B.
So what you can see is that, this diagram, just look at the diagram. And in this diagram, there is A box and then there is B box. So related to A box, you have got 5 options, A, B, C, D, E. You have to choose the correct option and write it down on a piece of paper with you. And for box B, you have to choose one amongst the 5. You can take the picture. Can you open the slide, Srishu?
So
Completely open it. So explain the hemodynamic effects of B. And this you can answer in 4 to 5 lines. And you can get these type of questions in OSCE also. I think we can go to the next slide.
Slide, Shishu.
Sorry, can I comment on that?
Yes, sir.
Okay.
Go back.
go back. It's an important physiology slide, but the problem at the bedside is I want to know from just the people who are in this panel, how many of you have done a forced exhalation test at the bedside?
None of us.
Okay, so
I have
I
not
think,
done. I'm Madhu, I have not done.
okay.
I have not.
So I think this is something that a pulmonologist does.
Yes.
Interpretation of forced expiratory volume 1 is, yes, it's important for us to know whether it's COPD, asthma, and all that. But
See, we have
how
put
many?
here, we have.
No. My only question is, it's a practical question.
Yes, please.
Whatever graphs and things that you're going to ask a 1-year candidate to do should be something that they are exposed to. They may be exposed to this in a lecture, but they are not doing it at the bedside. If you were to ask a ventilator graphics question for any of these diseases, that would be appropriate because that is something that they would see at the bedside. The forced exhalation technique is a very specific technique of pulmonary function test that pulmonologists do. This question is even, in my opinion, should not be there in pediatric critical care boards in the US. It appears in the boards, but I don't think it should be there because we are not exposed to this particular testing at the bedside. That's just my comment. I think you have to be careful when you're formulating questions is what is their exposure? While we may desire that they know all this physiology, we can teach this in the physiology. But if they're not exposed to it, they're not going to know. They're going to study for an exam and then forget about it.
Shekhar sir, can I just respond to that? I absolutely
Sure.
In fact,
If
this whole exercise of teaching the postgraduate was for that only, that we were complained that it's too tough. I totally agree. And in fact, this is also too tough. So while this is just a pre-test kind of a thing, and the whole purpose is the speaker is going to explain, and we'll see whether they get the concept at the end of it. I understand this graph is just kind of a base we are creating. This is kind of a thing which may give you some basic understanding explanation, and all throughout the lecture, hopefully the speaker will try to build up their knowledge where they will be perhaps able to answer this. This is not going to be a question in the exam. This is what we in fact faced in the previous things, but we are trying to give some basic physiology, and this is just a physiology. That's what is my understanding. Dr. Madhu, you can correct me if I am wrong.
No, that's absolutely right. And this figure also gives some concept about the functional residual capacity. Many
Something
people
of that
do
sort.
not even know what is FRC, what is residual volume, and all those things.
So what we'll go, Madam, what we'll do, we'll go ahead with the program as scheduled, and at the end, Dr. Shekhar and you all can comment on it.
Absolutely.
So let the
No
program
problem.
go. Let's go ahead, sir. Right?
Okay,
Okay.
Yeah.
let's
Go ahead.
with the
Sorry
talk.
for the interruption. Sorry.
Yeah. Okay, let's go ahead, please. Yeah.
Shrishu, you can read the
Shrishu, come on.
Is it not visible?
It is
Yes,
visible.
Can you just read it out? So it will go.
Yeah, you read it out, Shrishu, please.
Yeah. In this figure, A and B are the FRC of an infant and adolescent child. Which one of it is more likely to be of infant and why? Explain in 4 to 5 lines. Does the infant get fatigued earlier and why?
Can go to the next slide. Shrishu.
Next.
There's a graph given here. So a pointer, part of the graph is pointed out, and the question asked is what pressure does this represent? And the other small questions below it are identify the mode of ventilation from which this graph has been taken. Why do we need to see this? If it goes beyond the safe limits, how will it affect ventilatory mechanics and hemodynamics?
Okay.
The next question shows again a graph, and various numbers have been, various numbers have been given about the graph. There's number 1 here, number 2, number 3, number 4, and number 5. From the grid that you can see on the other side, you have to label which variable does it represent. So you have A as residual volume, B as FRC, C as total lung capacity, D as large vessel resistant, and E as small vessel resistance. So you will have to label accordingly which one of these number represents each one of them, and label it accordingly. Question number 2, West zone has been pointed out. Which West zone is likely to be at this point in the graph? Explain the relationship of, just a sec. Explain the relationship of pulmonary arterial pressure with pulmonary venous pressure and that with the alveolar pressure at this West zone.
Where is that West zone pointing to?
It's at here, sir.
Oh, okay.
Between A and B, there are 2 graphs shown here, graph A and graph B. The candidate has to say which.
In graph A, you can see resistance on y-axis and lung volume on x-axis, while the other one is exactly ulta, lung volume on y and resistance. So we want to know which one is right and why. Go ahead, Srishu.
There are 3 models shown here, each model representing one lung, as well as the lung is shown on the X-ray. The model shows a tube entering a balloon. So we have 3 models here. The blue is a normal size tube with normal balloon, corresponding X-ray shown along with it. Explain the time constant for yellow model and for the green model. The respective lung represents that the respective lung X-ray represents that model. As well as a figure of the time constant has been given here. There are 2 X-rays shown here, X-ray A and X-ray B. With respect to trans-airway pressure and trans-pulmonary pressure in the situation, with radiograph A and radiograph B, the candidate has to explain what are the changes that happens in trans-airway and trans-pulmonary pressure in both these situations.
Right. Thank you, Shishu, for those questions. I think what I will request the candidates to go through the lectures, and during the lectures you will get the answers for this. This is more of an applied physiology, not the exact questions. And please answer in the chat box. And I'll request now Dr. Prashant to go ahead with his presentation.
Yes, sir.
You can share your screen, Prashant.
Is it visible?
Yes, it is visible.
So, good evening, everyone.
Everyone else has to mute their.
Yes, please.
Except Prashant, everyone else.
So, we'll go through the basic topics about applied physiology of ventilation. We'll have few questions here as well, and that answer of those questions you will find in following slides. And try to look at that. So
Prashant,
the first question.
Prashant, please speak into the mic.
Mic, you mean?
Yeah. It's
Yeah.
Am I audible?
Yeah, you are audible, but you can come a little closer to the mic and speak. Yeah.
Okay.
Yeah.
So first question is, an infant with bronchopneumonia and an 8-year-old child with pneumonia, why infant is at higher risk of respiratory failure?
Dr. Prashant,
Yes.
Prashant, I think you please check your audio because it's going
Sir,
to be
I'm
very
taking-
high concentrated stuff and your audio is not very clear.
So I'm taking my this headphone off then.
Are you
Okay.
using my microphone? Are you using earphones?
I'm using this.
Then you
headphones.
try without it once. Just
Yes,
remove and
yes.
try whether it works
Yes,
without
yes,
that better.
Yes. Let me just take it off. Okay, is it better now?
I think so. Go ahead.
Okay. So my first question is, an infant with bronchopneumonia and an 8-year-old child with pneumonia, why infant is at higher risk of respiratory failure as compared to older child? So we'll start with the regulation of breathing. So first center on the top, which regulates the breathe, which starts the breathing rate, is located in our brainstem, and which controls and which starts the whole breathing rate from here. And we have few chemoreceptors in central and in a peripheral location. In central, there are chemoreceptors located in same brainstem, which respond to changes in CSF pH caused by increased CO2. That means hypercapnia is a strong stimulant for your breathing rate, and hypocapnia is a suppression of your breathing rate from your breathing center. Peripheral chemoreceptors you have in carotid artery and carotid and aortic bodies, which responds beautifully with the hypoxia, and hypoxia is a strong stimulator of your respiratory rate as well. On top of that, higher centers like cortex, they exert conscious control. That means you can control your breathing voluntarily, you can hyperventilate, and you can hold your breath voluntarily because of this cortical control. And we have few stress receptors located in the lungs. When you have inspiration, your lungs get stretched and they send negative inhibitory signals to your brainstem to stop the inspiration, and then it stops the further expansion of the lung. So here when you see, when we breathe in, your diaphragm contracts and your chest expands because of your external intercostal muscles. They expand the chest outside. You create negative pressure in the thorax, and you have, because of this gradient from outside to inside, you have air coming in. And when you breathe out, which is a passive movement, your diaphragm relaxes, your intercostal muscles relaxes, your chest coils back, which creates positive pressure in the thorax. And because of this positive pressure here and negative pressure, zero outside and positive inside, you expels out, which is a passive. But this is a passive at rest, but you can make it active voluntarily, like in a forced sneezing, coughing, or forced exhalation, or in some disease process like you have in an airway obstruction or you have asthma, you have forced expiration where you have the active expiration as well. When we talk about lung mechanics, we should know about the transmural pressure first. So in any small globe or a tube or a lumen, transmural pressure means a pressure inside minus pressure outside. So it decides that your globe or your lumen is expanding or collapsing. So if you have pressure inside more than pressure outside, that means you have positive transmural pressure, which is distending. And if it is negative, that means your lumen, your globe is collapsing. So when you look at the transpulmonary pressure, which is a type of transmural pressure, that means pressure in the lung, which is intra-alveolar, minus pressure in the pleural cavity, which is intrapleural pressure. So in the alveoli, pressure is nearly equal to your atmospheric pressure, which is 0 here. And in the pleural cavity, you have pressure slightly negative side, like -3 or -4. And your transmural pressure would be on positive side. That means you have transpulmonary pressure at rest, which is positive. That means which keeps your alveoli, which keeps your lungs try to open and maintains your FRC here. Trans airway pressure is like a gradient between pressure at mouth and pressure at alveoli. At rest, it is 0 because you have the same pressure in your mouth and in your alveoli at the end expiratory phase. But when you start inspirating, your pressure at mouth is 0, but because of this contraction of diaphragm and contraction of other muscles, you create negative pressure here as compared to outside pressure, and your pressure would be positive. And this, because of this positive trans airway pressure, you have air movement coming in. And when you have expiration, which is the passive, same thing, like you have the passive relaxation of the these muscles, and this thoracic cavity starts coiling back, creating positive pressure as compared to the outside pressure. It is +3 here. So this is the, like when you see that trans-airway pressure, which is negative here, that means the air is moving in a reverse direction, which is going out. This is passive expiration here. What is FRC? FRC means when you expire at rest. So what is the volume remaining in your lung is called FRC. And still we do have the gas exchange continuing during our FRC when we are not breathing. And why do we have FRC? Because our intrapleural pressure is negative, which is the main responsible factor to maintain this positive transmural pressure. And why this intrapleural pressure is negative? Because our thoracic cavity, which has tendency to coil outward at rest, which creates some negative pressure in the pleural cavity. And because of this negative intrapleural pressure, our transpulmonary pressure is always positive at rest, which maintains that extra pressure, which keeps the alveoli open, which keeps the lungs open, which maintains the FRC. And when you have anything collected in your pleural cavity, like it could be air, could be a fluid, could be some pus, which causes this negative pleural pressure disrupted, you might be carrying less negative or might be positive. So FRC is lost and they have alveolar collapse. Closing capacity. Closing capacity is like a volume at the end of expiration when your small airway start collapsing. Ideally, this closing capacity should be lower than your FRC, otherwise your all airways will get collapsed, reopened, collapsed, reopened with every breath, which is not a good idea. So in infants, the closing capacity would be slightly higher or equal to your FRC. That's why they have easy tendency to get their airway collapsed with any lung disease as compared to child or adult when they have closing capacity would be lower than their FRC. So still they have some margin to maintain their FRC, to maintain their alveolar volume. In this graph, when you see here, so blue one is the FRC and you have the orange one, these are the closing capacity. So when you see in the first year of life, this CC is more than FRC here. And when you see in the, like when you grow older and older year by year, your closing capacity comes down and your FRC goes up and you have significant difference, which is a good margin to maintain your FRC when you get sick, especially in adults and older children. So in which conditions when you have closing capacity more than FRC, that means you have high chances of having lung collapse. First thing is infancy that we know. Second thing is pneumonia or ARDS because your FRC is reduced. You have less alveoli available for ventilation. You have less volume available for ventilation. So your FRC is reduced. So your CC has become more than FRC. And you have something in the abdomen which is pushing your lungs up. You again have less FRC. So your CC has become more than FRC. And this PEEP, how does PEEP work? PEEP helps in increasing your FRC, helps in recruiting your alveoli area, which keeps your alveoli open. So it also helps in making your tendency to to get collapse, which is very, very less when you have extra PEEP given by HFNC or NIV from outside. So when you compare between infant and child, what do they have main difference in respiratory mechanics? So infant, they have compliant chest wall. So they have very poor mechanics for efforts. When they start having increased efforts, they have more retractions and more subcostal and external retractions. They don't have the rigid chest wall to maintain that, to hold that volume inside during increased efforts. While in children, they have a rigid chest wall and this rigidity increase year by year. Second thing, ribs are perpendicular to midline. So they are less effective chest movements. But in the children, they have downward orientation. So like a bucket handle type. So they have effective chest movements with their muscle contraction. And third is most infants are diaphragmatic breather. So they get fatigued very easily. And also abdominal pressure also interferes because of this pressure on the diaphragm. So that is also very important in their pathology. But in children, they are mainly thoracic breather. So they have less effect of abdominal compartment as compared to infant. So question number 2. a 5-year-old child with status asthmaticus admitted in PICU and intubated due to respiratory failure. He has severe bronchospasm along with hyperinflated lung fields. His peak pressures are very high. Why? Later on, his P plat, which is a plateau pressure, also started increasing later on. Why? So before we go through these questions, let's have a look on the compliance. So compliance means a change in the volume divided by change in pressure. That means for like how much pressure do you need to change a fixed volume? When you see here, so when you see this, like to generate that much volume, you need that much pressure here. But when you see this steep graph, that means with a small change in the pressure, you have a significant change in the volume. That means your compliance is better here. And this part is the poor compliance. Again, when you have overstretching here, again, like you are inflating a balloon. When you start inflating a balloon, initially you need to put some pressure to open it up. That means it has poor compliance. In middle part, you have better compliance. You can inflate it easily. And in the last part, when you have overstressed balloon, it's difficult to put more volume inside with your inflation. So you need lots of pressure for that because you are in this part of the curve, you are overstretching it. In PV loop, we have, this is inspiratory and this is expiratory, okay? And when you start off inspiration here, this part again, you have lots of alveoli collapse. You need extra pressure to keep them, to open them up. Here your alveoli are opening up slowly. This is the lower inflection point. Now they are opening up and then you have overstretching here and this is the expiration. So when you go to that, so why you see this inspiration and expiration different path? Because with the same pressure, when you compare, you have extra volume in the expiratory phase as compared to inspiratory phase. When you put a line here and then see the same pressure, you have more volume in the expiratory phase than inspiratory phase. Because this, when you are expiring here, that means your alveoli are holding more volume. They are not easily collapsing. They are not very easily collapsing. So they are having extra volume as compared to they had during inspiratory phase at the same pressure. And because of this, we call this extra space and the different path of this inspiratory and expiratory path. It's called hysteresis. And reason for this is the main thing is the surfactant, which keeps your alveoli open. When they are opened up, they don't get collapsed easily, but they have a different path. They have the extra volume while they are on the expiratory limb. When you see the PV loop on the PCV mode, I want to discuss all the modes because this is a different class. So just have a look on the PCV mode. You have the fixed PIP here. So your fixed PIP and you have different volume delivered depending on your compliance. So we have 3 loops, a yellow, green, and purple. Look at the yellow one. So when you have the fixed PIP and you have the highest volume achieved with this PIP, that means you have the best compliance. That means it's a erect PV loop. It's a straight erect PV loop. You see the middle one, and the purple loop has the lowest compliance. Lowest compliance, I mean, because it has got the lowest volume here with the same PIP, and it tells you a lot about your compliance when you are managing a patient on ventilator. In which conditions you have compliance reduced? Lung compliance and thoracic chest wall compliance. So lung compliance, the reduced FRC. Let's see ARDS, yes. So all disease which affects alveoli like ARDS, pneumonia, pulmonary edema. And when you have increased FRC, but compliance is still reduced, that means you have overstressed lungs, you have full lung like asthma or bronchiolitis, or excessive PEEP is also giving you extra volume in the alveoli if they are overstretched. Chest wall compliance, you have abdominal distension and chest wall edema. They are making your chest wall tight and they are very rigid and very difficult to expand. Airway resistance. So airway resistance means that when you push air through a tube or through airways, how much pressure do you need to generate that flow, that fixed flow, which is called resistance. That means change in the pressure divided by flow rate. That means if you have the fixed flow rate, if you need, how much pressure do you need depending on the airway resistance. That means delta P means, I would say, trans airway pressure difference between the pressure at mouth and pressure in alveoli, which is called trans airway pressure, divided by flow rate. Normal value is this. Look at this graph. Is it visible? So when you see here, resistance, when you start from the mouth here, it increases up to medium-sized bronchi and then comes down, and till your terminal bronchioles. And then it has the lowest resistance when you have in the respiratory zone in your respiratory bronchioles. Despite having very tiny diameter in respiratory bronchiole, they have the least resistance because they have collective diameter. When you see the numbers over respiratory bronchioles, numbers and diameter. So collective diameter is more in the distal airway. So they have the least resistance as compared to your medium-sized bronchi. Also, the flow in the terminal respiratory bronchioles, it is laminar and parallel as compared to proximal airways. Which factors affect your airway resistance? First thing, the length of tube. Tube means any tube. So I would discuss here about the ET tube. When any child who is intubated, make sure after chest X-ray is done, you have confirmed the tube position, which is correct. Cut the tube if possible to reduce the airway resistance if you are dealing with asthma patient. Radius. Radius is very, very important. And again, like if you have bronchospasm or secretions or size of ET tube, it matters. It also affects the resistance that we'll see in the next slide. And flow pattern, is it laminar flow or turbulent flow, depending on the how patient is breathing. If baby is very, very irritable and agitation, that will increase the airway obstruction. Someone who has airway obstruction should be calm and comfortable. More irritable they are, more resistance they have, and more difficulty in breathing they will have. So pressure required to get the flow, that means resistance, is equal to length and viscosity divided by 4th power of radius. Very, very important. If you make any tube diameter half, your pressure requirement or resistance goes 16 times, not like just double, 16 times. That's why when you are intubating a patient or with asthma or with any bronchospasm, use the largest possible size ET tube if possible, without any pressure effect around glottis. PV loop that we have discussed in the past in the few slides, like here, when you see the airway resistance, PV loop becomes bulging because of your high resistance, and is the expiratory and inspiratory part. So they have the bulging part, inspiratory and expiratory loop, because of airway resistance here. Peak inspiratory pressure, this is a pressure at the end of inspiration that we always know. Is a pressure required to deliver the flow to alveoli. From mouth to alveoli, how much pressure do you need to deliver a flow is called peak inspiratory pressure, which is a peak pressure. And this is a work against resistance, which is in the airway, and against compliance of lung and chest wall. So you have to work against two forces. First thing is the resistance in the airway. Second thing is compliance of lung and chest wall. So PIP is a pressure which has to overcome these two significant forces to make the flow delivered to alveoli. This is a very important pressure time scaler. So when you see here, breath starts here from the baseline pressure is the PEEP. It goes up and you achieve the peak inspiratory pressure, is the PIP. Okay, so you have got your volume delivered and now you have got your PIP achieved. Now flow stops. Now flow stops because the volume is delivered. So what happens now? It's called end inspiratory pause or inspiratory hold. When flow stops, no flow, no resistance. Because for resistance, you should have flow. So no flow, no resistance. So pressure comes down and stays here somewhere before it starts as expiration here. So this pressure, which is plateaus here, it's called plateau pressure. So always when you have the inspiratory pause or inspiratory hold, when you have zero flow area in your scalar, so when you have no flow there, your resistant part from a PIP will go off, and then you have only the compliance part, which is indicator of plateau pressure. So and then you have the expiratory part started here, and then it goes to the P. So this is PIP that we have discussed. This is a plateau pressure, and this part is indicator of resistance. Plateau pressure that we have discussed. So the pressure when flow becomes zero, it represents that we have discussed no flow, no resistance, and is a work against elastance and compliance only, because resistance part is gone. Now Plateau pressure is a true pressure in the alveoli, which is indicator of true compliance of the lung or chest wall. And when you see the difference between PIP and P-plat, that means it is purely airway resistance. So we have two scenarios here. First is a high PIP and normal P-plat, and second is a high PIP and P-plat, both are high. In the first scenario, when you see here, so suppose P-plat was like 15 here, and your PIP was 20, and now it's gone up to 25, it's increased. So P-plat remains same, but PIP has gone high to 25. That means you have increased the difference between PIP and P-plat. That means you have increased resistance. Could it be the secretions or spasm or tube block or tube kinking? So it is the airway resistance. In second scenario, you have the P-plat and PIP both are high. So P-plat also has gone to 20 from 15, and PIP is also going to 25 from 20. That means both have increased, but difference between PIP and P-plat remains same. That means the airway component is still the same, stable, but compliance part has gone worse. Third question: a child with acute asthma admitted in PICU, struggling to breathe with retractions and nasal flaring. X-ray is showing hyperinflation, and someone has planned to start on NIV or BiPAP to make him comfortable. Why PEEP, CPAP, and NIV when already has overstressed lungs? Could it be harmful for asthma patients? How does it help in spontaneously breathing asthma patient? That we'll discuss in next few slides. So what is PEEP? PEEP is a pressure at the end of expiration, which name says, which maintains the positive pressure in the alveoli. It keeps the alveoli open and maintains the FRC with best VQ and PVR, how we'll see later. And it also reduces work of breathing also, that we'll see later. In this curve, when you see here, breathing starts, again, you have to recruit these alveoli with the high pressures, and here you have some recruitment, and now it's going up, 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 again coming back, again de-recruitment. So alveolar collapse, recruitment, collapse, recruitment. To prevent that, why don't we start from here? And then when you have lots of alveoli already open, so you don't have to open them again and then open them again with every breath, which also causes lots of trauma on the alveoli. So when you apply the PEEP of 5, you start from here. So many alveoli are already open, already recruited, and then you have the very nice straight erected PV loop, which has the best compliance as compared to this one. So with the PEEP, you have which reduces end expiratory collapse. It avoids repeated collapse and opening. It recruits alveoli, so improves VQ ratio, and it also maintains FRC, which keeps PVR on the lower side. Optimum PEEP is a very common term that we see. How to know, like, what is the optimum PEEP? Actually, this is how to get the optimum PEEP. It is quite a different topic, that how to, like, you should have the recruitment and then all these step-by-step lung recruitment. We'll see here what is the optimum PEEP. Optimum PEEP means minimal pressure. This gives you the best effect without any side effect. So minimum PEEP required to prevent any end expiratory collapse of alveoli that are aerated at the end of inspiration without any hemodynamic effect of overdistension. That means no shock, no hypovolemia, no drop in BP, no barotrauma, no volutrauma. So that loop we have discussed here. So we have recruitment of alveoli starts here with LIP, and then it goes up. And here you see this is a stretching. So it's like making a peak, and this is the peaking, also beaking. Okay, that means it is overstretching. That means you have very, very poor compliance. Even after increasing the pressure, your volume increases almost nil. And when you start expiration here, this overdistension will get relieved first. So no change in volume, just change in pressures first. And then you start having all these alveolar collapse here. And then, so this is the upper deflection point. This is lower inflection point. So what is the optimum PEEP here? When you see here, this is the most safe zone, safest zone. This is the zone of collapse. This is a zone of overstretching. So this is the safest zone which we should ventilate a patient on ventilator. And when you see the line here, this is a line for LIP, lower inflection point. This is a line for upper deflection point. And then your PEEP should be somewhere here to keep the alveoli open without having repeated collapse, recruitment, which causes lots of harm. Auto PEEP, that means air trapping. When anyone who has airway obstruction, they have mostly obstruction in expiration. Means patient cannot expire easily. They have to do forceful expiration. So some part of air, some part of volume will be retained in the alveoli with every breath. And with some time, they have extra pressure developed in the alveoli, which is called extra pressure. Usually alveolar pressure should be 0 at the end of expiration. If they have positive side pressure at the end of expiration without any extrinsic PEEP, that means they have developed something inside which is called intrinsic PEEP or auto PEEP, or a simple term, air trapping. It causes increased effort to initiate a breath, to trigger a breath. How? We'll see. It causes alveolar overdistension. Yes, definitely you have extra pressure, extra distension, which causes compression of capillaries, which increases dead space. Because of overstretching and beaking, you are working at the topmost part of the curve here. And it causes reduced compliance due to overstretching. And with a high PI, and when you have high PIP and normal or mild increased P-plat, most of the PIP is lost, because when you have high PIP in asthma patients, this PIP should not be a worry, should not be like a thinking point, because this PIP is not going to harm the patient, because this maximum pressure will be lost in to overcome this extra resistance. And the main pressure which we should think about is MAP or P-plat, which is a main factor which is causing barotrauma in these patients. So PIP will be high, very high. Look at the P-plat, look at the MAP, which is the more important to determine the barotrauma here. So why do they have increased breathing efforts? Why do they have difficulty in triggering a breath when they have auto PEEP? Look at this picture. So this is a picture with without any PEEP. So they have auto PEEP of +10 here, and they have the expiratory outside pressure is 0 at the end expiratory before starting of inspiration. And so when they start the inspiration to make something trans airway pressure here +3, that means the pressure in the alveoli should be lower than outside pressure. That means it was 10, it has to be less than 0. That means it should be around -3. That means drop of pressure from +10 to -3. That means he needs -13 of pressure drop in his alveoli at least to start a breath. That means patient has to put lots of efforts to initiate a breath. That's why they have that difficulty in starting a breath, the difficulty to inhale when they have auto PEEP. How does PEEP will help? Let's see. So in the same patient, you put a PEEP of 5 outside, and you still have auto PEEP of 10. And now you have PEEP of 5 outside. To make the same trans airway pressure of +3, you need to have pressure less than 5, not less than 0, less than 5 now. That means your +2, that is less, like 3 less. So +2 pressure in the alveoli would be sufficient to initiate a breath. That means from +10 to +2, you need 8, -8 of pressure you need to start a breath, as compared to without PEEP, -13. The same patient, when you put the PEEP of 5, you need -8 of pressure difference to initiate a breath in the alveoli. Time constant, it is a time taken to fill or empty an alveoli by 63%. This is a definition. So one time constant which fills or empty the alveoli by 63%, and nearly all alveoli are nearly filled after 5 or 6 time constants. And time constant is dependent upon compliance and resistance of that structure. Let's see this picture first. So in the first, which is a normal alveoli, you have this curve going up. This is a volume time scalar. So this is a curve going up, and after the nearly 5 or 6 time constant, you get all the alveoli filled with your volume, and you have end of inspiration here when your expression starts here. This goes down. Okay. In next, when you have a restrictive lung disease like ARDS, which is affecting your alveoli, the compliance is reduced. So they have very short time constant. These are called fast alveoli. They are called fast alveoli. So they fill very rapidly, and then they achieve their volume, but not that much. They have a less volume because your alveoli are not all alveoli are available for the ventilation. So they have less volume available. It's called like baby lung concept. So less volume, but it is achieved very rapidly because of fast alveoli, and then they remain static, and then they start having expiratory phase. In next, when you have obstructive lung disease like asthma, they have increased resistance. So your inspiratory and expiratory I time both are increased. So you see that your volume is, you won't achieve that much volume. Your volume is less, and you take lots of time to achieve that volume, and it takes lots of time to expel that volume out. And that's why you need higher E time to give enough expiratory time to remove that extra air, to minimize the air trapping, to minimize the autopy. PVR. So pulmonary system is very thin walled and very low pressure system as compared to systemic site. There are two types of capillaries: alveolar capillaries or small capillaries, or extraalveolar, which are large capillaries. This is a diagram, and you see here, alveolar capillaries, they are lying in the alveoli here, the red one, and this blue one, which is called extraalveolar capillary, it's called large capillary. So what happens when you see the lung volume on the x-axis and PVR on the y-axis? So see the red one first. So when you have increasing lung volume, your PVR in small capillaries or alveolar capillaries is increasing because they are getting collapsed here. See here, they are getting collapsed here. When you see the blue one, which is an extraalveolar or large capillaries, their PVR comes down with the increasing lung volume, because when you have extra lung volume stretching, they are stretched out. So they are stretched out and they open up. So PVR in these vessels will come down nicely with increasing lung volume. So when you combine them both, you see this PVR goes down first and then start increasing after certain lung volume number. So at this point, when you have the highest PVR and the low lung volume here, which is called the residual volume, and this is the highest PR on the high lung volume, which is called total lung capacity here. And this part, when you see here, when you have the lowest PVR, at which volume you will have FRC. So that's why our all efforts are to keep the lung volume at FRC, to minimize the PVR, whether it is with the PEEP or keep them open or try to avoid repeated collapse. Which factors affect PVR? Pulmonary arterial pressure and venous pressure, yes, definitely. Lung volume that we have discussed, lowest at FRC. Hypoxia, acidosis, and hypercapnia. These three are very strong vasoconstrictor for pulmonary system. So if they are present, you will be struggling with the PVR. We should keep them on the lower side, like hypoxia should be corrected here very aggressively. Hypercapnia should not be allowed with the patient who has high PVR. VQ ratio, so we have discussed about ventilation. What is this? Moving air in and out. And perfusion, which is a perfusion of alveoli from right heart. And this is a very basic diagram. It comes in from right heart, comes in the alveoli, gas exchange happens with ventilation and goes out in the left lung. Dead space which does not take part in the gas exchange. Two types. First thing is anatomical, which is from nose to terminal bronchiole. Second thing is alveolar. Few alveolar space, few alveoli in the lungs, they do not have proper perfusion. So just ventilation get wasted, it comes in and goes out without any perfusion and gas exchange. So these alveolar space is called alveolar dead space, which is contributing to 1/3 of total dead space. Very interesting, how do you have the change in the ventilation when you have erect standing lung position? So top part, when you have top part, there is nothing which is pressing this alveoli, and you have the largest size of alveoli because your gravity and your lung weight is pulling these alveoli down, and they are overstressed. So there is no scope to stress further. So they do have lowest ventilation, lowest change in the volume on the top part. When you come to the middle part, alveoli are still stressed, but not that much, because now some pressure of the lung is coming over them, and which is compressing them. So they are the medium-sized alveoli. They have good scope, good expansion with their air movement. So they also have good ventilation. But lowest part, which has lots of pressure from top because of your lung weight and gravity, and from bottom abdominal compartment, your diaphragm, your organs, liver, they are pressing these alveoli, and these are the smallest size alveoli. So they have largest scope to expand. So they have largest or highest ventilation as compared to top part. So your ventilation increases from top to bottom. So when you see here a change in the size from here, not much, middle part, yes, and the lowest part, the maximum change in the size. So you have the largest ventilation in bottom part. Perfusion, because of low pressure in the pulmonary system, it is very, very dependent on gravity. So the top part gets least perfusion because of high gravity in the standing, I'm talking about a standing position. Middle part gets a sporadic or some sort of like moderate, and lower part gets the highest perfusion as compared to top part. West has divided the lung into 3 or 4 zones, depending on the pressures in the alveoli and in the pulmonary arteries and pulmonary veins. So let's see what happens here. In the zone 1, you have the largest alveoli, and you have very least perfusion, least pressure in the pulmonary artery. So pulmonary arterioles. So because of this least pressure in the pulmonary arterioles and highest size and the highest pressure in the pulmonary, in the alveolar pressure, so these arterioles are collapsed. So they have least perfusion in this zone, and it's like they have the good air coming in and out without any perfusion. So it works like a dead space. In zone 2, you have some perfusion coming in the alveoli because of gravity, and your alveolar pressure is also coming down because of you have some pressure from outside. So here you have arterial pressure is more than your alveolar pressure, which is more than your venous pressure, which is I think a best area to have better VQ matching and better gas exchange. In the bottom part, you have highest volume, your capillaries are full of blood, but your alveoli are very, very collapsed and very, very small size. So they are not matching actually. We have excess amount of blood, which is not getting exchanged with air from alveoli. And this blood is going wasted, going back to the left heart without any gas exchange, which is part of shunt. So interesting part here is, sorry. PEEP, how does PEEP work? What PEEP does, when you apply PEEP in this zone, so PEEP will increase the pressure in the alveoli. So this alveolar pressure will come here in the middle. So it becomes this one. That means zone 3 becomes zone 2, and you apply excessive PEEP in zone 2, which we do not want, but zone 2 becomes zone 1. So a lung is not a homogeneous, lung is like a heterogeneous organ, which has different zones, different ratio. So you can't say that this PEEP will help in this zone or in the all lung part, because few parts might get over distension, few part of lung might get better recruitment and better VQ matching. VQ ratio, when you see here, it should be ideally 1, but some blood from your bronchial veins come in the left heart, which is causing some sort of lower VQ ratio. It's like 0.8 ideally in the human body. And when you see here, this is a top, this is a bottom of the lung, this is a standing position. So V is going up and Q is also going up from top to bottom, it's increasing. But when you see the blood flow is increasing disproportionately more than ventilation, so your VQ ratio will decrease from top to bottom. And this is the highest VQ ratio you have, which is the top part, and which is called dead space. And this part is a bottom part, which is giving you lots of shunt area here. So when you have the disease alveoli, which is completely full of exudate, and when you have blood coming through and going without any gas exchange and causing shunt and causing hypoxia, how does body react? In the disease alveoli, like ARDS, this perfusion is going waste. So what happens actually is hypoxia in that alveoli, is localized hypoxia in this alveoli, stimulates vasoconstriction of that alveolar capillaries, which divert the blood away from these disease alveoli to healthy alveoli, and it improves your VQ mismatch. High VQ conditions, like when you have more than 0.8 or 1 VQ ratio, when you have high V, you have low Q, that means your ventilation is not being utilized fully and going waste. It's like a dead space region when you have decrease in the Q or high in the V. So when you have decrease in the Q, like you have overstretching of alveoli, like air trapping, asthma, it causes stretching and compression of alveoli, or you have excessive PEEP, like you are working in this part. This is causing your high VQ. Or you have significant clot or thrombus in your pulmonary emboli, which is causing almost 0 Q in that area, or you have blocking vessels. Low VQ means it is less than 0.8. That means you have dead space, shunting. So some part of pulmonary perfusion is going back to the heart without any gas exchange, it's like a shunting. And so you have poor ventilation due to airway block or some ARDS or pneumonia, but your Q is perfect, your V is not good, so you have some blood which is not getting exchanged with air. How does prone positioning work? So let's look at the supine position first. So in the supine position, we have gravity here. This is the anterior part. Anterior part is the posterior part. And you have transpulmonary pressure, which is reducing from top to bottom. And like we have discussed in the standing position, when you have top lung part has the maximum sized alveoli. So here also you have the over distended alveolus, and the bottom part, because of weight of lung and weight of heart, both causes this area is like collapsed or very small size alveoli, which is causing this area. So you have low VQ, it's like a shunting area. You have very poor ventilation, but perfusion is good, so which is not getting exchanged and then going back. So what happens when you make them prone? Okay, so first thing, you are taking this weight of lung and weight of heart off. So your alveoli, which were collapsed here, which are now opening up here slowly, and alveoli which were over distended here, now they are less over distended. That means they are getting relief from this over distension. That means you are opening those alveoli which are collapsed, and you are relieving those alveoli which are over stressed. That means you are working on this part of the curve in the prone position. That will help in your VQ mismatch. So prone positioning, what it does, it does recruitment of the dorsal space. It causes more homogeneous distribution of V and Q with a better VQ matching as compared to supine positioning. And due to the reversal of weight of lung and heart, change in the chest wall shape, and there is a reduced pressure from the abdominal organs when you are prone as compared to supine. So to conclude, I will put some light on the few keynotes that we should consider while thinking about respiratory physiology. Surfactant and negative pleural pressure keeps alveoli open at the end of expiration, which maintains VQ mass to get the best gas exchange. And this negative pressure is because of your positive transmural pressure, because of your recoiling tendency of your chest wall. Parenchymal pathology needs repeated recruitment open lung, and keeps lung open with the PEEP. low volume lung ventilation, because of ARDS, you have very, very small alveolar space available for the ventilation, like a baby lung. So you should use the low volume to prevent the overstressing of these alveoli. And it also prevents barotrauma and polytrauma. So we should use the low volume to maintain that alveoli in a normal stage. And we should keep doing the repeated recruitment and continue with the PEEP to keep them open, which helps in that disease management. NIV helps in initiating breathing efforts in asthma patients by reducing the effect of auto PEEP. And ARDS has multiple pathologies for hypoxia. Means are VQ mismatch and diffusion limitation. Thank you.
Thank you very much, Prashant. I think that was a very, very large topic. You covered it very lucidly. A lot of hard work has gone into it. And I think Prashant has covered right from breathing physiology to trans airway pressure, transpulmonary pressure, airway resistance, pulmonary vascular resistance, compliance, West zone, auto PEEP, prone ventilation, and whatnot. I think it was very difficult to cover in this given time. He's made the best kind of effort. And I think those who are hearing this for the first time, it is likely to be difficult, but I think this can be just the initial introduction to this particular topic, which is very important for all budding intensivists. And I think you need to follow it up by reading books and, interacting with your own faculty. And I do think that, you can discuss between the peers, and teaching is the best way of learning is what I feel. I think we have got one of the best experts, and this topic is very, very close to Shekhar's heart. I think I'll give this floor to Shekhar for his expert comments.
I want to first commend Dr. Prashant for it's a very difficult topic, like Madhu said. There are a lot of complex things that you have to explain. He did, I would say, a very, very good job. But I do have some concerns about not using very standard terminology in both the talks. And in my chat, I have pointed out some of the problems with the standard terminology. Right now, I don't know how much time we have to go over them. If you want, you can go through the questions and I can point out what the problems are. I've made my comments very clear on the chat about specific points. The point I want to make is, when we are talking about volumes and capacities, Manish was correct in saying that when you say volume, tidal volume or expiratory reserve volume or total lung capacity, it refers to a volume at a particular point in time of either lung inflation or lung deflation. It's a volume remaining in the lung. So residual volume is the volume remaining in the lung at the end of a normal tidal breathing. All these definitions are only for spontaneous normal breathing. Unfortunately, we take that and put it in a patient who is on mechanical ventilation. That is a mistake. Because if you take a normal person and you give him 10 centimeters of PEEP, you're not increasing their normal FRC. What you're doing is you're increasing the lung volume at the end of exhalation. So a lot of physiologists have suggested to use the term end expiratory lung volume when somebody is on mechanical ventilation, rather than use the concept of FRC, because that actually describes the lung volume at the end of PEEP. So when you increase the PEEP, your end expiratory lung volume changes. When you decrease the PEEP, your end expiratory lung volume will decrease. Because if you actually take the PEEP off, it will go to residual volume. What happens in ARDS is the residual volume is lower because of atelectasis, consolidation, and surfactant problem. So when you apply PEEP, you actually recruit the lung and restore the volume. But I think it is better to refer to it as end expiratory lung volume. I think, unfortunately, whatever the previous speaker has said is actually what is described in standard textbooks. But I think when you teach, you should make that point to say, and when you derive questions, I think it will be better to use end expiratory lung volume, and then with a little explanation what end expiratory lung volume is in the question. So that's number one. The second point I want to make is, can I show a couple of slides?
Yes, sir.
Yes, sir. Please.
Yeah.
How do I share the screen? Share screen. One second.
Prashant, I think you have to stop sharing first.
I have stopped that.
He has stopped sharing, ma'am.
Khushi, can you please help out?
Can you see it now?
Yeah, we can.
Yes, yes, sir.
It's okay. I was going to do like a slideshow, but I can show you these slides. Okay. So this is from my from the book that we recently published with Dr. Sarnaik. So I want to show you these two side-by-side pictures. On the left-hand side is volume control ventilation. On the right-hand side is pressure control ventilation. And I won't describe this because I think everybody knows what these graphs represent. The top one is the pressure, the middle one is the flow, and the bottom one is tidal volume. What is important to understand is that when you create a pressure volume loop on the ventilator, it basically takes each time point for the pressure and volume and then reconstructs the pressure volume loop. So I'm going to show you the pressure volume loop that you will normally see with volume control and pressure control. Okay, everybody shows the pressure volume loop on the left-hand side when they describe how to adjust ventilation, how to adjust PEEP, what happens in ARDS. But remember that that is a dynamic pressure volume loop that you obtain only during volume control ventilation. During pressure control ventilation, because the pressure goes to a maximum very quickly, there is no inspiratory part. The inspiratory part is totally useless. You don't get this kind of nice curve on the inspiratory side when you do pressure control ventilation. Just go to the bedside and look at it. So I think it will be a mistake to present somebody with having some disease on pressure control ventilation and then show the volume, the graph on the left-hand side. That's a mistake. Now, if you look at the flow volume loops, they also look different. Because remember, the flow is decelerating in pressure control, whereas it is constant in volume control. So the flow volume loops are also different. So this is something that I think you need to pay attention to. So therefore, if you go to changes in lung mechanics, for example, if you were to do ARDS, this is what you will see. You have the normal, and then as the compliance goes down, for the same pressure, you get less, higher pressure, you get the same volume. So your curve shifts to the right, there is less hysteresis. But I want to show you what happens with pressure control. With pressure control, the peak pressure will be the same. It is only the deflation curve that's going to be different. And the tidal volume that is reached at the end of peak pressure will also be different. So you cannot show this curve and have a patient be on pressure control ventilation. Okay. Let me close this. The other thing is about west zones of the lung. When Dr. West described the zones of the lung, these were all lungs that were taken out, or patients were spontaneously breathing. So these were isolated lungs, or they were patients who were spontaneously breathing, volunteer subjects. He did not describe any form of intrapulmonary shunting with his zones of lungs. Those interpretations came much later. And it's wrong to say west zone of the lung when you're talking about intrapulmonary shunt. You get shunt only when there is zero ventilation. The correct definition of shunt is when you have zero ventilation. There are only two conditions where you have zero ventilation: atelectasis and consolidation. And only atelectasis is amenable to airway pressure maneuver. Consolidation is not. But you can have venous admixture or desaturation even when you don't have ventilation equals zero. And the mechanism for that is it takes a while for the blood to get fully saturated by the time it goes through the capillaries. In the normal, it takes only about a third of the distance. By the time the red cell goes to a third of the distance, it's fully saturated. But now imagine a lung segment. There is an alveolus and a capillary where the alveolar ventilation starts to decrease, but the perfusion remains the same. Then it'll take a little bit longer and longer for the red cell to get fully saturated. At some point in time, the ventilation can reduce to such an extent that the blood does not fully saturate. That will now produce desaturation. But that's in a person breathing room air. Most of our patients are on high FiO2. So these segments may or may not contribute to venous admixture. So when you're describing ventilation perfusion relationships, these are the complexities about ventilation perfusion relationships. So for a first-year candidate, they should be able to say that in ARDS, you have lung segments that produce intrapulmonary shunt. The two major reasons are consolidation and atelectasis, period, bus. If they can say that, I will be very happy. I will say, okay, what do you do about atelectasis? Okay, apply PEEP, do recruitment maneuver. Great, that's a correct answer. Anything more, you have to be a physiologist or you have to be very intensely in that field to understand it, because it's much more complex. So I think the way the physiology has been described by both the speakers is excellent, but they have so much detail. You have to bring it to the bedside to say, okay, which of these things is important for the student to give me an answer, not to understand. Their understanding will be whatever amount of time they spend reading about it. But when you ask a question, there should be a minimum level of answer that they should be able to give. I would try to focus on that. This physiology is so complex, is so detailed. Each one, it will take probably 20, 30 minutes for each item to be described in detail. I mean, I can do that, but I think there's not much time.
I think, Shekhar, you're absolutely right. I think this complex physiology at the end of the lecture, we must say what is the clinical relevance for a first year or 1 year student. So clinically, so when we're asking question, it should be relevant for his clinical training, not as a physiologist, but I think he should have a basic understanding, but the relevance, as you said, is we should ask basic questions about how to use this physiology clinical bedside, rather than asking the hypothetical question.
I agree. And I think when we teach them, we can remove a lot of the more detailed explanation and focus more on what, let's say, 99% of the intensivists should understand.
I agree.
And only focus on that. If some student who wants to show off his knowledge or her knowledge asks you a question, then you can answer that question. But I think our teaching should also be directed towards keeping it really, really, really simple with an explanation.
Would agree more.
Agree.
One of the things I've always enjoyed is listening to how other people give the same talk. I mean, I've heard Madhu and Dr. Chugh. They explain these same physiology in such simple terms. It's very easy to take a take-home message. That's the way it should be. My comments are all in the chat. So you can take a look at my chat if you want. You can print it out. And then if you have specific questions, please email me. I will answer them.
Thanks,
Dr. Shekhar, one question here. On the bedside, Raju, can I take it? Hello?
Please.
Hello?
Please, Mahesh.
Yeah, just one question on the bedside. Can you determine whether it's a dead space problem or a shunt problem, and to what extent and how to titrate? On a bedside with given parameters, can you determine, apart from the history of the child and X-ray, so how can you do that?
Yeah. See, anytime you talk about dead space or shunt, you have to have measurements. So for dead space, at least minimum, you should have an end-tidal CO2. Because if you have increased dead space, the difference between the arterial PCO2 and the end-tidal CO2 will increase. Normally, it's less than 5 millimeters of mercury. It can increase more than that. That's a very simple way to say that you have increased dead space. But you cannot calculate it based on just the end-tidal CO2. You need a little bit more sophisticated equipment for that. Shunt, you just use the P to F ratio. P to F ratio is a good surrogate for shunt fraction. So if your P to F ratio is 500, that's more a normal lung. If it's less than 300, it's ARDS. Or you have oxygenation failure similar to ARDS. It's not necessary that all patients with less than 300 have ARDS. That's only one of the definitions of ARDS. So those two things, if you have end-tidal CO2, without end-tidal CO2, you cannot tell about dead space. Without some CO2 measurement, both in the airway as well as arterial, you cannot tell anything about dead space. You can stand at the bedside and explain that maybe dead space is going on, but unless you have measurements, you cannot do it. Does that answer your question?
I think so.
Sorry, go ahead.
The other point I want to make is everybody teaches this. I have also taught this. You know how we say lower inflection point, upper inflection point, safe zone. That curve, that pressure volume curve is generated by using static pressure volume loop method.
Sure.
That means one of the methods you use is take a syringe, you put in a certain volume, see what the pressure is, put another volume, put another, keep on increasing the volume, and then do it deflation, and then reconstruct. That curve will show lower inflection point and upper inflection point. The curve that you see on the ventilator is not static pressure volume loop. There are a lot of people who will try to find out what the inflection points are, and they are wrong because that's not the physiology. So when you teach about the safe zone and upper inflection point, it's very important to tell them that this is generated using static pressure volume loops, which we don't do in pediatrics at the bedside. I mean, I can do it at the bedside. I have done it, but we don't do it routinely. It's very important for them to understand that. And a lot of textbooks don't mention that is the case.
Are there any questions from the audience? Prashant?
Ma'am, right now, there are no questions there.
Yeah. No questions right now. So we can go to that explanations that Dr. Madhu and Dr. Shishu.
I think Prashant has covered it.
Yes.
Can we just skim through the questions? I can tell you, maybe we can reword the question. We can all discuss how some questions are straightforward. Some questions, there's a lot of confusion in the way the question is structured.
Khushi, do we have
Let's go
time
to the
about beyond 10 p.m.? Just confirm from the DIP platform. Khushi?
8:30 to 10.
Yeah, let us ask from the Khushi if we can for a couple of more minutes.
We should be having a little bit more time.
Yeah, just ask for the DIP platform. Khushi?
Minhaj, we have usually up to 10:30.
Okay.
So go on. She will indicate if there is any up.
Okay. Done.
Go to the first question. Okay, I already mentioned about this question, right? I think, in my opinion, this should never appear in any exam. It should appear in textbooks and that's it. Because we don't use this technique at the bedside.
Okay, next.
Okay. The problem, the question doesn't relate to the figure that you have shown.
Checker.
Yeah, you're talking about FRC.
Yeah, I changed it to hysteresis.
Okay. And make it a little bit more different. They look very similar. So make the curves a little bit more pronouncedly different.
Maybe the curve with a lesser compliance should be showing it downwards to say it's a little less in an infant and a better one in an adolescent child.
Yeah, you can change the orientation so that they look more contrasted difference.
Okay.
Now you have no, go back. The first part of the question, that's fine. Which is more and why? Explained in 4 to 5 lines. That goes along with this particular figure. The next question does not go with this figure. Does the infant get fatigued earlier? There are so many other reasons for the kid to get fatigued.
Agree.
Such as, can you explain?
Yeah.
You want me to explain?
What we wanted here people to say is that the ribs are transverse. So they have got limited capacity to increase the anteroposterior diameter, point number 1. Their FRC is lesser. Their closing capacity is close to FRC. And also the musculature is easily fatigable. They have got less type 1 fibers. So
Correct,
these are
correct,
the
correct.
answers which we expected. So please correct us.
Okay, Madhu, you're correct
Uh-huh.
in explaining
Uh-huh.
why an infant will get fatigued earlier.
Mhm.
My suggestion is not related to that.
Mhm.
Your questions need to be related to the data that you're giving them. The only data you're giving them is basically hysteresis and compliance. You're not giving them any questions about whether, what is the age of the infant, what is this thing. Not all infants get fatigued earlier.
Okay.
It depends on when the, and
a detailed question. Okay.
yeah. So what I'm saying is the question should be related to the figure that you're showing or the data you're providing.
Yeah.
Okay.
Yes, sir. I think the point is well taken. Probably, I think the reason for putting this question was because he was explaining about the functional residual capacity versus the closing.
That's correct. That's correct. That's
yeah,
correct.
But I think the question should not have come in this slide. Probably could have come in the next slide.
What I'm saying is, I'm just pointing out a point. That is, make sure that the figure or data that you provided, the question matches that data. Don't ask a question for which some other data is relevant, but not the data provided in the question.
Yes, the point will be sure. Sir.
Okay.
Yeah.
So go to the next slide. The West Zone.
No, this was the one you asked. You said there is some.
No. The West Zone. Go to the question on the West Zone.
This is the third question, Shekhar.
Oh, okay. This is the third question. Oh, this I have no problem with this.
Okay.
This is very straightforward.
Because you mentioned that there is a problem with these questions.
Oh, no. I might have made a mistake about the order of the question. Sorry.
So I think in the
Dr.
chat,
Dr. Shishu,
we were talking
Dr.
about
Shishu, since these talks are going to, hello,
Yes.
Anjul, since we are going to archive all these things for a review for the students, I want you to give a standard answer to these questions before switching to the next slide. So we as a faculty, you all know that, but let the students also know what is the standard answer.
The standard answer would be plateau pressure or pause pressure. The mode of ventilation would be volume control ventilation. What is the next question? I can't see it because it's
Why do
covered
we
by...
need to see this pressure? Why? I think it meant, why do we need to monitor this pressure?
I think that goes beyond the scope of this question.
Okay.
That's too many questions in this one particular. If it goes beyond the safe limits, what is a safe limit for a plateau pressure?
It is 30.
I mean, the recommendation is to try to keep it below 30 centimeters.
30.
Yeah.
It doesn't mean that 32 is
Bad.
unsafe. Okay, go to the next question. It's incorrect to talk about West Zone when you're not talking about pressure. Lung inflation has two effects. One is to change lung volume. The other one is to change intrathoracic pressure. So West zones of the lungs have been described in relation to pressure, not in relation to lung volume.
Okay.
So it's incorrect to talk about West zones of the lung for this figure.
Okay.
Okay, but Shishu, can you just answer the first part of the question, which is related to the residual volume and FRC and total lung capacity?
Yeah. So number 3 would for residual volume, it will be the least one. So number 3 would be residual volume.
That is incorrect.
Why?
this particular figure, the highest PVR when the lung volume is low is actually at atelectasis. It's not residual volume.
Okay. So you,
4 is FRC, that is correct. 5 is
will be
total lung
total
capacity. 5 total lung capacity, that can be correct. And large, it should be, it should not be called large vessel or small vessel. The correct terminology is extra alveolar vessel or alveolar vessel.
Alveolar vessels. Okay, so Mahesh, when we put it, I think we will make these corrections and then put it.
Yeah, we'll do that.
Yeah.
Go to the next one. Okay, I have a problem with this question.
Hmm.
How does lung volume relate to resistance?
Correct. So as the volume increases, the resistance falls.
No,
After a
that's
certain-
not correct. No. As you inflate the lung, resistance of what falls?
alveolar, I mean the airways.
Airway resistance. This is airway
Which
resistance.
airway? Which airway?
Smaller airways.
Smaller airways. Initially,
but
there is
how do
increase, and later on it is less.
No, I understand that, but it's not very specific.
Okay.
Because the intrathoracic airways,
Hmm.
the large airways will actually expand because of the negative intrathoracic pressure.
Yeah, from trachea to the bronchus, it will expand and that it will increase. But beyond bronchus, below bronchus, the resistance goes on decreasing as the lung.
No,
volume-
it doesn't. It does not decrease. It is only under specific circumstance of hyperinflation that then causes dynamic obstruction that the resistance will increase. Resistance increases by lengthening the airways. That is a possibility. So what I'm saying is it's not very straightforward that lung volume, an increase in lung volume will increase resistance. And therefore, I think this will be a very confusing question. And we as teachers will not be able to answer if somebody were to ask a counter question for us. See, as teachers, we should be able to give very straightforward answers to questions that we are posing. This is very confusing to me. I understand what you're saying, Madhu, but the question is not specific enough for it.
I think we have one question in the chat box which is related to this, asking for Prashant, why do we apply PEEP in a case of an asthma patient?
PEEP in asthma patient has nothing to do with resistance. It has to do with work of breathing. Prashant explained that very nicely.
Yes, sir.
It has nothing, it has very little to do with resistance. It has much more to do with the initial effort of breathing.
Yeah.
By reducing the transpulmonary pressure required by the patient, you are reducing the work of breathing. So this has nothing to do with asthma and the application of PEEP.
Yeah.
I think to me, this is very confusing. I'll just go flip a coin and go A or B. Okay, next question. This is perfect. Absolutely perfect question. Very nice.
So basically,
but what you can do is match. You can put the overinflated X-ray with C. And the normal lung with B, and then the ARDS one with the last one. So, and then say which of these things correspond to which of these X-rays. This is very nice question. I like it. I like the figures too. Okay, next
For
question.
audience, can you just finish off the questions? Explain the time constant in yellow and green mode, so you can just.
No, I would not, because that's asking too much in a question. Time constant has to do with resistance and compliance. You're not providing anything. You're just providing a model that shows either increased resistance and overinflation, and then corresponding X-ray. If you want to explain time constant, try it with a different question.
Okay.
Okay, next.
This can be separated into two separate questions. Because trans-airway and transpulmonary pressure are two concepts. Now you're introducing two separate conditions that will confuse them. Take one condition and ask them to describe the trans-airway, transpulmonary pressure in this situation. A second question can be another situation, trans-airway and transpulmonary pressure. Especially for one-year candidates. I think if you separate them into two separate questions, that'll be good.
You know, Shekhar, all these questions were meant to stimulate them before Prashant speaks on this particular topic. So it will produce some questions in their mind so that they will attend and they will listen to the lecture more carefully. So that was the sole purpose of having 6-7 questions, you know, nothing else.
That's fine. That's fine. I'm just suggesting that when you formulate questions, this question is a little too much. If you separate them, it'll be fine.
Sure.
Actually, sir, these are not the real exam questions that we are going to put. This is just, as Madhu madam said, because to stimulate their thinking.
I understand. I understand. My point is, don't have two situations with two separate physiology that you're describing.
Right. Yeah, we got that point, right? So.
No, but Anjul, what Shekhar is trying to say that we should have questions, like we said, this is for the fellowship exam, sort of model questions for them. So what he's pointing out is that it should be more relevant for the one-year candidate. I think we take your point, Shekhar. I think it is quite well taken. Yeah. So it is more of a first,
because trans-airway pressure, trans-airway pressure, transpulmonary pressure is actually very advanced physiology. It should be for the DM candidates and for the 3-year fellowship candidates, maybe even 2-year fellowship candidates. 1-year fellowship candidates, I think it's a little too much physiology to ask them to understand.
I agree.
If they do, that's great.
I think being the first lecture and then very complex topic, I think we would the next one we would know how to moderate the questions better. I think you being there and being a master of respiratory physiology, it is always but I think it does help us.
I'm no master. I'm still learning. Every day I read, I'm learning something new. So
I think even masters learn, it's all right.
Rajiv, I think these questions, if you had sent me these questions, I would have said no point attending this class. They're just too complicated.
Yeah.
Let's keep them simple.
Very simple.
Let's stimulate people to add on to their knowledge rather than say, oh, this is just too much. Let's.
Yeah. I think it puts people off. I think we need to ask them gently.
No, I mean, you can use these pictures during Viva exam, and if somebody has passed, you can use some of these complex ones to say, okay, you will get a higher grade if you can answer this question.
Right. Shekhar, I think you might not be aware, we have changed the exam pattern from this July. Because of the exam pattern is changed, and the first paper, which is going to be 70 MCQs, is going to be asking a lot of physiology sort of thing. That's why the respiratory physiology was chosen as the first one, but we should be keeping it more simpler for 1 year. I mean, I know I can see where you're coming from, but the physiology needs to be asked. But for the first year candidate, has to be very, very moderating down rather than this complex.
I agree, but the physiology that you want them to answer should be, one, demonstrable at the bedside,
clinical,
simple enough to understand and explain.
I
The
agree.
more complex ones, even physiologists are not able to explain very clearly.
Absolutely. So Anjul, is there anything, any comment?
You want to do Prashant's questions? Oh, but they're not in a format. Okay.
Yeah.
Prashant's questions were basically more to the start of the topic that he was going to say, and that's why he predicted those questions.
Can you just quickly go through your slides? I have a couple of suggestions for you.
Yes, sir.
I'm sorry to hog the time.
No, sir. So I'm just sharing my screen. There you go, sir.
Go ahead. Okay. So it would be very nice to ask the question after you present a lot of these things, instead of asking the question right in the beginning. Okay, go through quickly. I don't have any problem with any of these things. Go ahead. Very nicely explained. I already talked about what volume and capacities are. Capacity is basically when you have two of those volumes added together, it's capacity. So FRC is residual volume plus expiratory reserve volume. You mentioned at the end that the alveoli are maintained, FRC is maintained by surfactant as well as the negative pressure, the positive transpulmonary pressure at the end of exhalation, but you don't mention anything about surfactant early on. I think surfactant is a very, very important factor in maintaining the stability of the alveoli and preventing it from collapsing. It's not just I think that is more important than the transpulmonary pressure.
Okay.
But what you need to mention, I think this is the clinical relevance. In diseases like ARDS, the surfactant component of it gets damaged. And therefore, you're left with only pressure to maintain the lung volume. That is why you need PEEP.
Yes.
Okay. So if you mention that, they can then synthesize the information of what happens with atelectasis and why PEEP helps. So surfactant is more important than transpulmonary pressure, but when surfactant goes away, transpulmonary pressure is the only one you can manipulate to try to increase the lung volume.
Yes.
And that figure, that where you have closing volume, that should be closing capacity.
Closing capacity. Okay.
This is all fine. So closing capacity means that the airways, not alveoli, airways collapse at that volume.
Yes,
so when airways collapse, then the alveoli will collapse.
Yeah, small airways. Yeah.
Yeah.
The difference between infant and child.
This last part is not correct. All of us are diaphragmatic breathers. Even adults, the major component of breathing is actually diaphragm with some percent with your chest. So it's incorrect to say they are thoracic breathers. You can say they have more stable thorax.
Okay. Yeah, second questions.
Okay. So I have a question for the people who are in the, who I can see on the video. How many of you ventilate severe asthma patients with volume control, and how many of you do pressure control?
I do volume control.
Volume control.
Initially, sir, volume, then
I
it
do
needed
volume.
to change to pressure.
I have
What?
also used PRVCs at times.
Okay. So why would anybody want to use pressure control or PRVC in a patient with asthma?
I think, Shekhar, you need to, when you ventilate asthmatic, it is what you want to see, that it is what is your plateau pressure rather than the actual tidal volume itself. So if you P-plat, you actually ventilate them on a P-plat, not on the peak pressure. And so you do not, volume, they say in asthma, you have to have a low tidal volume. You can use, if you want to see the mechanics, I think volume control is better to see the lung mechanics.
Okay. If you ventilate an asthmatic with low lung volumes, your PCO2 will be very high.
Yes, it would be.
Yes. Either you decide that all asthmatics should have permissive hypercapnia, which is not how we do it.
Well, you do accept a little bit of a permissive hypercapnia in
Yeah,
asthmatic.
that's okay. So the way asthmatics, ideally, especially if you have people who don't know enough about mechanical ventilation to take care of them, it should be volume control. And I'll give you a few reasons for it. One, you have a fixed tidal volume given by the ventilator, which then is distributed between the circuit and the patient. When the patient gets better, there is less in the circuit and more goes to the patient, but that difference is not substantial. So when you put somebody on with asthma on on volume control, your plateau pressure may be only 20, your peak pressure may be 45.
Absolutely.
Okay. And as Prashant explained, that peak pressure is, you don't have to worry about that peak pressure because it's actually not, the alveoli are not seeing that peak pressure. It's only the proximal airway pressure that sees the peak pressure. And so when the patient gets better, all that will happen is the peak pressure will come down. The plateau pressure will roughly stay the same or maybe go up a little bit because you're having a little bit more tidal volume going in.
Sure.
If you're on pressure control, the problem is going to be, I can guarantee 100% of the time, or let's say 99% of the time, your I time is going to be too short. And therefore, you will not see on pressure control the tidal volume reaching a maximum at the end of inspiration. If you now do a plateau inspiratory hold, you will see that there is a plateau pressure lower than the peak pressure in pressure control. Okay?
Right.
That means your I time is not optimized for pressure control. Because of the time constant, you have to have a very long I time in order for them to get a complete inflation with pressure control. Now assume that the patient actually gets better. And some patients get better very quickly, and some patients get better very slowly. Let's say you take a patient who gets better very quickly, and your peak pressure is 32 or 30. Okay, and your plateau pressure is, let's say, 24. Now, when he gets better, his resistance has gone down. He needs less time. His tidal volume will increase with the same peak pressure. Now your plateau pressure will start going closer to the peak pressure. So you're now going to inflate the lung with a higher tidal volume, which is already hyperinflated. So the potential for air leaks is a little bit greater with pressure control ventilation. Unless you come to the bed space almost every half an hour, 1 hour, take a look at it and keep making changes on the ventilator, then I don't think all those things I should worry about.
What about PRVC mode, Shekhar? A lot of people are using pressure regulated volume control.
To me, PRVC is just a fancy way of doing pressure control. The first few breaths, after a change in resistance, until the ventilator kind of figures out, okay, I'm giving too much tidal volume, it's not going to adjust the peak pressure. So the patient will get bigger tidal volumes for a few breaths until the tidal volume comes down and the peak pressure comes down. So PRVC is not necessarily safer. And if you allow spontaneous breathing in PRVC, you'll see a lot more asynchrony, especially with asthmatics. So my preference would be just volume control ventilation, and the patient gets better, the peak pressure will automatically come down. You don't have to worry about the plateau pressure at all. Anyway, go ahead. Next question. This good? Good. I already made the point about the curves. Go ahead.
Yeah. This one
okay.
You said. Yeah.
I already showed you graphs why this cannot be PCV mode. In PCV mode, the pressure goes from PEEP to the peak pressure very early in inspiration.
Would be like this, or would be like this?
No, there will be no curve. It'll go straight and then go up like that.
Okay, like
ideally.
Okay.
Yeah, that is correct.
Okay.
What you have drawn, the second one is perfect.
Okay.
The exhalation side will be the same. This side will be the difference. Okay, next one.
These are theoretical parts.
Yeah, those are all perfect.
Yeah. Resistance. Yeah.
Okay. Oh, let's go back. Okay. In a diseased patient, you cannot assume this.
No.
In a normal patient, in distal airways, the airflow is laminar. When you hear breath sound, especially in asthmatics, you can hear them inspire all the way until they start exhaling and exhale all the way until they inspire. That means there is no laminar flow anywhere. So the flow and things are very complex because most of it is turbulent. Very little of it is laminar. Okay. This would be true for laminar flow, but that's okay. It's making a point about the resistance and radius. Remember, this is only for volume control.
Yes.
This is not for pressure control. Okay. This is only for volume control.
Yes, sir.
Everything is perfect. This is very good explanation.
The third question. Is about PEEP, how it works.
Okay, I have a problem with the sequence of the slides. Go back to the case.
We are talking about the role of PEEP in the asthma patient.
So you're talking about a patient with already with acute asthma.
Yeah. But I'm
who's
talking about
probably generating autopy.
Yes.
Now you are introducing PEEP physiology.
Normal physiology for PEEP, including all patients like asthma and ARDS. Yeah.
So that picture should be with the patient with ARDS, not with asthma.
Okay.
This would be relevant for a patient with ARDS, not with asthma.
Yeah. Optimum.
This would also go with ARDS.
Yes. So,
yeah, now this can be part of your discussion about the asthmatic patient.
Yeah.
Beautiful explanation. I really like your figures.
This is made by me only.
I like it, that's why. It's not taken from some book. You actually wrote down the numbers. I really like it.
Yeah.
Go ahead. This one also, I like it. Very nice. So it's very important. In asthma, it's the same tube through which you inspire as well as exhale. That means your time constant during inspiration is also increased. That means you need a longer time for the same tidal volume to be delivered.
Yeah.
Longer time for the lung to be exhaled. So in asthma, we tend to think only as an exhalation problem. It's not. It's both an inspiratory and an expiratory problem. That is why low rate, fairly large tidal volume, I to E ratio does not have to be 1:3 or 1:5 or 1:6 or something like that. It can be 1:2, but low rate so that you have a lot of E time for exhalation.
Good, sir.
Go back. Instead of capillaries, just call it vessels.
Okay.
Alveolar vessel and extra-alveolar vessels.
Okay.
Technically, only the alveolar vessels are capillaries. The extra-alveolar vessels are the small arterioles and venules that attach to the capillaries. This is a very nice slide. I like it. So my suggestion would be, don't show any of these gravity gradients. Okay. Just show 3 or 4 separate alveoli with different sizes, different tube thickness for the perfusion. And then you can explain the physiology. And then you can use this figure to show the zones of the lung. And I also mentioned about shunt.
Yes, sir.
Shunt is not a part of west zones of the lung.
It's the extreme of the VQ mismatch.
Yeah, it's part of VQ mismatch, but it's not part of west zones of the lungs. So just historically, the west zones of the lungs were described when he was working as a physiologist fellow in London.
Okay.
The ventilation perfusion relationships were described in United States in Rochester. And he did a fellowship with the group that described that ventilation perfusion relationship. So he did not describe that relationship. He only described the zones of the lung.
The tone conditioning, how does it affect?
So in this, I think for the students, you can just, this figure is a little misleading because all that we know from the literature is that better VQ matching.
Yeah.
We don't really know the mechanism of better matching because Amato has shown that in ARDS during prone positioning, there is not a gravity dependent gradient of blood flow. But there is better VQ matching. So you could explain this with this figure, but mention to them that this is only a theory. There's definitely better VQ matching. That data is there. But one of the mechanisms could be this. Another mechanism could be without any gradient, there is better VQ matching. What you say about ventilation is true. What you say about perfusion is not necessarily true. That's my only point. Go ahead. This is correct. You know where this is correct. Go to the next one. You mentioned surfactant here, but you don't mention surfactant early on in the talk. And surfactant should be mentioned first before the transpulmonary pressure.
I mentioned when I was discussing about hysteresis. I mentioned
I know. Yes. Yeah, I think you did a very good job. It's very difficult. Very difficult. I don't know if what I said made any sense. I just stopped.
No, sir, it was good points. Like, well taken.
So Anjul, I think we need to wrap it up. Yes.
Yes, sir.
Yes, sir.
So, yeah, I like to thank everybody, all the panelists, and especially Dr. Madhu Madam and Dr. Shishu for being the experts, and Prashant did a very good job. And Prashant, you presented your presentation probably the person who's the best person in the universe to talk about ventilatory physiology.
Yes.
And if you have come out with the remark saying that you did a good job, you really have done a very well job, I think. And I think this initiative of the classes where the faculty is taking an initiative to make the presentation and present it for the sake of the fellows, the motive behind Rajiv Uttam sir and Mahesh Mohite, what they want. I think it's a wonderful exercise. And I really thank the faculty for taking that time out to present. Usually we leave this job to the fellows and just give the expert comments. So I think Prashant has done a very good job. And I think we cannot thank enough Dr. Madhu Madam, and who's our teacher, and Shishu for giving the valuable inputs as an expert for the session. And I thank Dr. Mohite sir and Dr. Rajiv Uttam sir, Dr. Kishan Chugh sir for attending this, and thank my team for doing this.
I think, Anjul, I just want to make one point to the fellows who are attending, that it's not going to be as confusing for you in the examination. I think this is just, you can see that how much the input has gone, and the answers have been modified. So don't worry about it. We're not going to ask you these difficult questions, but this a point that you should be reading about this. And I think in next lectures, Anjul, we should be doing the lectures. When you're doing the talk, maybe we can have a clinical application after each couple of slides. What is the clinical relevance? So these people will be, knowing it better. But I think you guys have done a wonderful job, and you and your team, and thanks very much for initiating this wonderful.
Just 1 minute. Slide maybe whether we can next time, since we are having a lot of questions on the way, we can have 2 or 3 good students on board, while on the talk, they can answer those questions when the talk is on. That can give really more flavor to the session.
That's fine. That's
So we can
fine.
have 2-3 students from maybe exam going students or 2 years candidates who can come.
One last suggestion. For the younger faculty who are going to be presenting, please do avail yourself of the senior faculty who have done this a lot. They can go through your talks and maybe make some corrections as to some terminology and things like that. I think, to me, I've listened to Madhu and Christian. They are very, very clear in what they want to convey. I mean, there is really no doubt when you walk out what they have actually said to you. So I think I would utilize them, just to go through the slides and say, hey, that's a very good job.
Shekhar, the conveners are same. They're going to be different speaker, and the experts are going to be different in different lectures. But what I was going to ask you, are you free on first and third Wednesdays, or if we share
I'll try.
or if we share these slides with you in beforehand, maybe you can give us your input to us, what needs to be done better as well, so we can share these slides with you as well.
I can definitely do that with the slides. As far as attending, I'll try my best. I mean, if someone can just send me in my email, the dates, like the first Wednesday, what is going to happen, second Wednesday, then I will try my best to attend as many as possible.
So maybe Anjul, we can do that with the Dr.
We'll do it, sir. We'll definitely do it, sir. And the slides also, in case if sir wants, we can always send the slides beforehand so you can have a look, or we can have a small Zoom talk before that so that we can just rush the slide through him.
It's not an obligation. Don't make it an obligation. Don't make it an obligation. If a faculty feels like they want to talk to me about it, I'm willing. But don't make it an obligation, please.
Of course. Okay, Anjul. So
I'm sure everybody's extremely busy. Don't add one more layer of difficulty.
So Anjul,
I'm still a bacha in physiology, so I'm still learning.
So Anjul, just say a vote of thanks, and I think we should call it today.
Yes, so on behalf of this team, we thank profusely our the Vice Chancellor, Sir, Dr. Rajiv Uttam, sir, and the Chairman of the Society chapter, Dr. Mahesh Moite, sir, for initiating this process. And we profusely thank Dr. Shekhar to be with us and going through each slide and helping us out, and Dr. Madhu Madam and Dr. Shishu for being the expert, and all the panelists who have been there in the session, Dr. Nameed, Dr. Dhiren, Dr. Chuk, sir, and I thank Dr. Prashant for giving this wonderful talk, and Dr. Manish and Dr. Minaz and Dr. Lalita for going through all the rigors of getting this act together to start this program, and thank all the fellows who have attended, and I hope they've been equally benefited by learning a lot about the ventilatory physiology.
What is the session tomorrow?
It's a mental.
I think topic.
I'll just check. I'll send it across.
Neurological topic.
Neurological topic.
Neurology, yeah.
Acute encephalitic syndrome, from the PGI team.
Okay. Thanks, everyone. Good night, everyone. Good night.
Good night.
Thank you, everyone. Thank you.
मिनाज तुम म्यूट पे हो.
He was. Wait a minute. I think we'll. Okay. चलो हम लोग मिलते हैं बाद दोबारा हम लोग कल परसों मिलते हैं ठीक है. I think it went very well. Lot of good learning and
It's always a constructive criticism. See, I mean,
Yes,
physiology can
yes.
never be complete.
Yes.
Whatever you do a 1 hour
Yes.
session, do a 5 hour session, there will be a plus and minuses.
Yes.
And
I think at the end of the day, it was very good. It was very good. At the end of the day, it was really good. Whatever has been discussed out is not that already. I mean, इतना आसान नहीं उसको discuss करना, उसको लाना, एक platform पे लाना, उसको बोलना. I think it did very well. Let's see how we go about. Okay. Thank you. We'll do.
Okay. Bye.
Bye. Thank you, Khushi. Good night.
Yeah. Thanks, Kushi. Thanks. Yeah. Bye.
Thank you, doctors.